Thanks, Dr. Muhammad, for this very nice presentation. And we'll move to the coming one, which is by Dr. or Professor Chandra Shakir. He is a changing algorithm in craniopharyngioma surgery. Dr. Chandra Shakir, he's a honorary consultant, professor, and head of department in Mumbai Hospital, India.
Thank you for the kind introduction. We have changed our management of craniopharyngioma. Understanding the molecular biology of craniopharyngioma. Basis, and probably our management will evolve over the next few years. Morphologically, I think when we look at the craniopharyngioma, we usually talk about a cystic lesion, a mixed lesion, or a calcified lesion. A purely solid lesion is not so common, though occasionally can occur. If we look at the operative strategy for craniopharyngiomas, Cushing gave the name craniopharyngioma and described it as the most formidable of intracranial tumors. And probably the first successful surgical resection was by a transsphenoidal approach by Halsted way back in 1909. Donald Mattson, in his remarkable series in 1969, gave us a more than 40 cases operated before the advent of steroids and given a reasonably good results at that time. Clinical presentation wise, we either get neuroendocrine disturbances as the presentation of craniopharyngioma, more commonly neuro-ophthalmological deficits, especially in countries like ours where people do not present to us early. In children, raised intracranial pressure is a common mode of presentation, and occasionally you may get psychological or motor deficits if the tumor has grown too big without noticing it early. And patients presenting with a rapid visual deterioration and raised ICP require early intervention. Most others can be planned properly. So what are our goals of treatment? Our goals of treatment are to improve vision, to decrease the intracranial pressure. And I think the cure from tumor takes the third space, because many a times it may not be possible to do it keeping the good functional status, which is equally important because many of them occur during the growing years. And you will find that, similar kind of tumor, similar kind of surgery, you can get a normal looking boy developing into an adult, and some people develop obesity and other hormonal disturbances quite commonly. And therefore, if we look at what is the best treatment or what is the standard of care for craniopharyngioma surgery, the Cochrane collaboration actually told us that most people recommend it for the research, because though half the people felt almost that it is likely to be beneficial, there was an opinion that it can also be harmful. The main reasons for this are the objections to aggressive theory, is because is there a separation between hypothalamus and the tumor which can be easily dissected out, and therefore these are several stages where people started removing subtotally and going for radiation, as radiation seemed to have some role there. If we talk about only choice of surgical treatment, surgical excision still has the most important role. Should it be gross total or subtotal resection is probably being debated. Radiosurgery has found a place in this, and intracystic therapies are also important, especially in very young or mainly cystic tumors. The main areas of controversy, as we just talked about, is the extent of surgical resection, and then also the surgical approach, and then use of adjuvant therapy. Not only what adjuvant therapy to use, but which kind of radiation should be used, and is there any role of the newly developed biomolecular markers. Surgery is dictated in most cases by the direction of the tumor growth, and choice of surgical approach has a strong influence on outcomes, especially in retrochiasmal tumors. There is no consensus, though, as to what is the best surgical approach for this tumor, and endoscopic surgery in recent years has allowed the endonasal approach to be used more commonly, and also an intraventricular endoscopic approach is also possible. So I think if you have a sellar tumor, then I think it is very, very reasonable that the surgery is going to be transsphenoidal, either endoscopic or microscopic. Endoscopic surgery is becoming more and more common. When you have an intraventricular approach, I think there is no doubt that the approach is going to be a transcranial intraventricular approach. Again, you use a microscope or endoscope, depends on preferences, and has some advantages for either. The main concern is the large suprasellar tumors, which require a greater degree of individualization. So this is a typical case. You have a cystic sellar, or what we call infradiaphragmatic tumor. And this is one patient, 13-year-old girl with, you can see almost the diaphragm is stretched up, and there is no question about what is the best route to approach. We approach it with endonasal transsphenoidal surgery, and you do a slightly extended approach, take out a little bit of the frontal base, and then you ligate the anterior intercavernous sinus, open the lesion till you actually reach pituitary. Whenever there is a prechiasmal tumor, the pituitary is going to be at the back. So usually you do not interfere with the pituitary, and the cyst is being completely exposed. And once that is done, then you start removing the tumor. You are removing the calcified component. Now I am dissecting out the capsule. And eventually you come to a stage that the whole tumor could be completely excised without getting any CSF leak, because most of the tumor was restricted to sella, and we have not interfered with the stalk either, as you can see from this postoperative pictures. Intraventricular craniopharyngioma, we have written our experience in Frontiers journal recently, about 24 cases, where we have shown that the best is probably endoscope assisted transventricular approach. This is a typical example. This is a recurrent tumor, mainly in the, there is hardly any component in the sella. The pituitary is intact, and this is the kind of tumor which has been endoscopically decompressed, and we've got virtually a complete excision by endoscope assisted procedure. So it is the suprasellar craniopharyngioma where we are still not sure what is the best way. If you have a prechiasmal tumor, which was the earlier classification to show its relationship with the chiasm, the bifrontal or the pterional approach is being favored more common, as Professor Sami has repeatedly said, that you can probably have a better exposure, but more deficits with a bifrontal approach. And in retrochiasmal approach, in a retrochiasmal craniopharyngioma, though lamina terminalis approach was our earlier approach, and petrosal approach by, as described by Al-Mufti, also has a great application. I think it is the endonasal endoscopic approach which is becoming more popular, and this certainly seems to be the kind of lesson which we have learned over the last few years, because the retrochiasmal tumor seems to have more morbidity if you approach it transcranially. Once you talk about an endonasal transsphenoidal approach, we are talking about the possibility that the tumor could be in front of the infundibulum, within the infundibulum, or retroinfundibular, and this gives a lot of importance as to how you are going to approach it. So here This is a young girl where the pituitary is displaced behind, most of the tumor is in front and going suprasellar, and it becomes much easier. Again, similar kind of a procedure, ligation of anterior intercavernous sinus, removing the calcified component of the tumor, and then slowly pulling out the cyst and teasing it out along with your suction being used as a dissector. And then eventually when the tumor comes out, you reach the third ventricle, see the aqueduct as well as the both foramen of Monroe quite well, and get a complete excision. And this is the girl who has developed quite well. It is about 9 years now following surgery. And she had a very small residual component which was seen after about a year, and she was given radiation, but she is developing well. This is a transinfundibular kind of a case, which is very difficult in terms of preservation of pituitary stalk. However, once you have exposed the area and once you have seen the normal pituitary, you can develop a plane of dissection. And eventually you can see that I am taking out the tumor capsule from the infundibulum. The manipulation does cause some deficits, but they are usually reversed if you do not cut the whole infundibulum completely, and she's also developed quite well. Now, in this kind of a situation where there is a large cyst behind the pituitary, you need to drill out the dorsum sellae. And this is one patient. We have done 3 patients like this so far. Once you have done that, you push the pituitary in front, and then you start operating behind and trying to remove the tumor from behind. And this is the kind of cyst that has been completely excised. And for 5.5 years, this lady was without any recurrence. Then a small solid nodule appeared, after which she was given radiation, and she is doing well now 12 years after surgery. Technical limitation of a non-aerated sphenoid sinus also does not exist now with routine use of navigation, and you can drill this out quite well with the high-speed drills which we have available today, and a complete excision has been achieved in this patient as well. Recurrent tumors can also be treated, and this is one patient who had a cystic lesion predominantly, was operated, did not follow up, developed a recurrence, and again we are operating with the transsphenoidal approach. And you can see that the tumor capsule is being sort of separated from the stalk, and then you are entering into the third ventricle here again. So this is where you can see the basilar bifurcation nicely in the interpeduncular fossa, and the stalk has been nicely preserved here. Post-surgery, you see both the foramen of Monroe and the aqueduct here. This is the post-operative picture. When the lesion has a broad stalk and going even in the sylvian fissure, it is possible to approach through this approach, like in this particular boy, where you can see that we have been able to take out the sellar tumor. The suprasellar tumor is now being brought down. And once that has been done, once the it is identified that the pituitary stalk has been preserved, we are trying to look to the one side. I have had to drill a little bit further here to see where we are. And then you can start seeing that you have entered the sylvian fissure here, and you can start seeing even the middle cerebral artery after the nodule from here has been completely removed. This is the post-operative scan of the same patient. When you have a largish tumor and when the patients present mainly with hydrocephalus, what we have started doing is not only to drain the put a EVD or drain the ventricle, but drain the cyst directly. Like in this patient, we do an endoscopic procedure to aspirate the cyst and to put a drainage tube in the cyst. And 2 days later, after the child has been fully worked up, the neurological status has improved a little bit, then we go for endonasal transsphenoidal excision and remove the tumor completely. As you can see in this patient, that is a fat pack which has been kept, and the tumor has come out completely. We have described this combined endoscopic approach in the management of suprasellar craniopharyngioma, successfully carried out now in about 27 patients. On the other hand, you can probably even stage your surgery. This is a large tumor. We first did a transcranial approach, and we have been able to excise this tumor quite considerably. And after the excision of this tumor, you can see that some part of the tumor is still remaining in the sella. Rather than going for radiation, we thought we'll give it one more try. And we operated on this patient through the transsphenoidal approach after about 6 weeks. And you can see that the whole tumor could be nicely removed here. And this is the post-operative scan. The best thing is this patient also has virtually no diabetes insipidus, and you can see he is developing quite well on a 5-year follow-up without any radiation and preservation of stock even in such a large tumor. So I think in children, you need to be more careful. You probably can err on the side of subtotal or not err. I think rightfully do a subtotal excision followed by radiation therapy. While in adults, you are more likely to do a radical excision. I think in children, there are some anatomical considerations, but it is possible to operate on children above the age of 3 years by endonasal approach. If you can take care of other issues, if your team is used to this kind of care. I would end up by giving you an example of this patient, that this is a very large tumor again, which we tried to remove endonasally. After 2 attempts, we have still not been able to dissect it completely because of the adherence to hypothalamus. And you can see a small amount of tumor was remaining. And with proton beam, this has been treated quite well. And it is about 5 years now. And there has been 4 years now. And there is no recurrence. Mild cortisol and thyroid supplementation is being given. Craniotomy primarily is reserved mainly for a predominantly paracellular tumor when it is heavily calcified, or if there is a vascular encasement, or if there has been any previous surgery which has caused injury either to any important structure like optic nerve or carotid artery. So this is a management of about 165 procedure in 118 patients, and endonasal transsphenoidal approach is becoming our primary approach in last 10 years or so. Other important thing is our observation, as well as there is a paper now which has shown that probably the hormonal disturbances are lesser in number, and more important, lesser in intensity in the endonasal transsphenoidal approach. And this is some of our patients in growing years who have been operated for this disease. So my take-home message would be that I think the treatment of craniopharyngioma is changing, and individualization is the need of the day. You have to see what is the age of the patient, what is the morphology of the tumor, what is the hormonal status of the patient before you decide how you are going to treat this patient, and then follow it further logically. Thank you very much for a patient listening.
May I call on the stand and participant to if they have questions now? Any questions?
Be happy to answer any questions.
Thank you, sir.